Good morning, everyone. It is my great pleasure to introduce our distinguished speaker, Professor Ajay Mahal. A little bit about Professor Ajay Mahal. He's a professor of health economics and global health systems research at the Melbourne School of Population and Global Health. He is an internationally renowned health economist whose work focuses on health systems, health financing, human resources for health, and economic evaluation. Throughout his distinguished career, Professor Mahal has held academic and research appointments at leading institutions, including Harvard T.H. Chan School of Public Health, the World Bank, the University of California, Berkeley, and the Indian Statistical Institute. His research has informed health policies and health systems reforms across many countries, helping governments make evidence-based decisions to improve health outcomes and strengthen healthcare delivery. The topic for Professor Mahal's lecture today will be on health systems resilience and the relevance of labor markets. Please join us in giving him a warm welcome. Thank you.
Well, good morning, everyone. And thank you very much for coming to this session. I'm delighted to be here. This brief talk will essentially make 2 points. One is that we can think about resilience in very simple terms. And number two, that thinking about resilience without really sort of looking at the role of health labor markets is probably not going to be quite useful. So basically what I will do is try to argue that there is relevance, important relevance of health labor markets when looking at questions of resilience. Okay, so with that sort of very brief prelim statement, let me sort of begin with what one means by resilience before we get to health sector resilience. And I had a difficult time when preparing for this talk to sort of arrive at any single definition. There are many, many definitions in the literature, many of them informed from the climate change and the commons literature. And I didn't find that very useful, but the one that did stick with me is the idea of the capacity to persist in the face of stressors. It's not about capacity to resist, but to persist. That is, take whatever form, but when facing the stressors, to continue to perform in some way. That's the sort of definition I liked, and that's the one I'm going to be using. But before I do that, it's probably worth noting that if you open up journal articles on health sector resilience, you will see a diagram such as the one on the left as the typical way in which health sector resilience has been understood. The basic idea is that if you get hit with some sort of shock, and there's literature because it came out of the whole discussion around the Ebola epidemic in Africa, in West Africa, and then sort of was reignited in the context of the COVID pandemic. It's sort of, it's sort of focused primarily on, I shouldn't say primarily, but certainly to an important extent on important shocks like this, natural disasters, infectious disease, pandemics and epidemics. And typically the questions that are asked is, well, is the system able to absorb the hit? That is it able to continue to function at the same, sort of more or less the same pace as it was with some minor adjustments? Another notion is that of adaptive capacity, which is basically saying, okay, perhaps if the health sector is hit with a huge shock, you increase funding by a bit, or you can find funding from somewhere else. So as an example, or you can assign health workers from one area to another. So that would be an example of sort of adaptive capacity and some task shifting and so on. And then we talk of transformative capacity, and I guess this idea of transforming a system in response to major concerns. So we can think of a health sector reform, for example, as something transformative. And you've seen how difficult it is for Malaysia to, going through several rounds of proposed health sector reforms. And I suspect this is still a long, ongoing process, and Malaysia is not unique. Most countries have that sort of challenge. Um, but what I'm going to do is to define it in terms of a very simple set of ideas that a health system's resilience can best be judged by its ability to perform what it is supposed to perform, which is access to good quality services, a degree of financial protection, ideally in a manner that's equitable, and at a cost that's sustainable. These four elements should form part of any reasonable definition of resilience in the face of stressors. And so, what do we mean by stressors here? Well, usually people get worked up about Ebola and COVID and so on, but I think there is a sort of ongoing series of stressors which we need to be concerned about, which actually I think may turn out to be much more important. And the first one links to financing. And for those of you who lived in Malaysia, you would immediately understand that public sector financing for health has been a constant, if you will, a stressor for the health sector, certainly for the Ministry of Health, and for a lot of people who benefit from public services. But also, there is the whole demographic pressure. Malaysia is an aging society, is aging not immediately, but it's going to be aging in the future going forward. And it also has a growing burden of non-communicable conditions, heart disease, stroke, cancers, and so on. And these are going to be stresses as well. These, of course, not short-term hits, but they're certainly pressures that are going to continue to exercise influence on the health sector on an ongoing basis, and ultimately, the system would have to respond. And that's certainly part of a resilient story. Okay, with that in mind, let's get a flavor of what some of these shocks might look for you. Papua New Guinea, an island of about, well, nobody knows exactly what the true population is, but let's say it's around 11 million, no, I think 10 million by the government estimates. And what you can see immediately on the left-hand side chart, which is looking at expenditure on per capita on health in real terms. This is adjusted for inflation and so on, and looking at trends over time. And what you see quite remarkably is the amazing bouncing around of financing for health. Can you imagine a health sector functioning on that basis where funding is not guaranteed from year to year? So here's what we are seeing. So we have private expenditure per capita, which is low in PNG, but both the public expenditure per capita, which is in orange, and the stuff in green, which is external aid, and PNG is quite heavily aid dependent, is literally bouncing around from year to year. Of course, local funding, because PNG is heavily commodity dependent, and since Malaysia also exports oil and palm oil and so on, also partly commodity dependent, it's certainly an issue, but even external aid is quite bouncy. So at some level, the system is getting hit with shocks on a year-to-year basis. Now, 1 year or 2 years, it doesn't matter, but on a continuous basis, when you have shocks like these, that will certainly affect the resilience of the system. And you can see it on the other side. I mean, just to sort of make sure that you understand what I'm trying to get at, if you look at the right chart, that tells you on the one hand, the health sector budget is partly bouncing around, is a health sector share. But if you look at the revenue per capita and the tax revenue per capita, because revenues include tax plus non-tax revenues, like, sale of assets and no, I shouldn't say sale of assets, but, returns from public enterprises and so forth. So you can see it's bouncing around quite a bit. It's not a stable, the revenue system is not providing revenues on a steady basis. So that's certainly an issue for PNG. So two sorts of volatility, external aid as well as local revenue raising capacity. Both are creating volatility for the health sector budget as well. And that's the sort of stress I'm talking about. Now let's go to Malaysia, a country that you're of course very familiar with. And if you look, and this time I'm going to move to the right-hand side of the right chart. If you look at the right-hand side of the two charts, the right-hand side of the slide, you will immediately see that Malaysia's revenue story, although quote-unquote steady, is pretty unchanging over time. So per capita revenue from tax and non-tax sources and per capita tax revenue is basically pretty steady over time. It is not showing a huge increase. And that should be of some concern, because if you look at other countries, typically you see rises over time. But more importantly, this is occurring at the same time as the share of health in the budget is rising over time. And what's basically what it's trying to do is to sort of cope with the rising healthcare needs, and the share is rising. But the government doesn't like that. Certainly, the Ministry of Finance is sort of challenged by the fact there is a rising health sector burden, government health spending burden on its overall revenue sources. So what it has been trying to do for the last, I think I would say, quite a long period of time, trying to sort of hold the line on public spending. It's going up, but going up at a slow pace. But in turn, what that has done is given rise to a private sector, which is rising at a faster rate in Malaysia. So you see, if you look at the left chart now, look at private expenditure per capita and government expenditure per capita. Private expenditure is rising inexorably. So again, it's a reflection of a stress, which is a revenue stress, which is showing up on the left-hand side, which is in a rising share of private spending. Now, on the face of it, you will say, so what? Things are going on, people are getting health services, and so what's the concern? Either, PNG is not doing as well as Malaysia, but you could say, so what? And what I'm going to try to argue now is that it'll help us as we go along this route to think carefully about how human resources matter and how health labor markets are going to influence over the longer run the resilience, the capacity of these systems to respond to these shocks. But before I do that, one final set of thoughts, which is around another shock, stressor, which is moving so slowly as to be hard to see on the face of it, just like climate change, as it were. And if you look at Malaysia, for example, this long-term stress has essentially around demographics. So the share of population which is older is rising, not unique to Malaysia, as globally. But we also see increasingly that certainly beginning around 2020, the ratio of the people who are in the 15 to 64 working age group, if you like, young adults, as it were, young and middle-aged adults, the ratio of their relative to the non-working groups, primarily elderly, is declining over time. That is, the dependency burden is going up. It's not necessarily a bad thing, but certainly that's something to think about. And of course, on top of that, we have to overlay the growing NCD burden also. As older people tend to get sicker, they have more chronic conditions. So this is another stress, as it were, longer moving. But as you have seen, that the health sector's capacity to adapt and so on is not very quick either. I mean, they've tried 8 or 9 efforts at health reforms. Not much has happened, right? Slow changes at most. So certainly that's another stressor to think about. Now, PNG is slightly different in this regard. The PNG's ratio of working age population to non-working is actually increasing still, and it's expected to increase up till 2060, 2070. So dependency burden may not be an issue, but there is a disease burden which is growing rapidly, and this is the disease burden on account of NCDs. Certainly, there is an existing communicable disease burden, but what's seen more sharply in the data for PNG is the rising share of chronic conditions, again, cancers, heart disease, and so on, and occurring at much younger ages. So in fact, even though the working age population is rising, even that is not totally expected to be free from the burden of NCDs. It can be quite significant going forward. So again, this is another stressor. It comes in the shape of the health side of the population, unlike Malaysia, which certainly has the health side, but also a growing dependency burden. So these are stresses on the system, and the question is, how might the health sector respond? Are these systems going to be reasonably resilient in response to this? And what I want to do is to use the notion of the health labor market to shed some light on how these stressors might work. So and to motivate this, since I'm going to focus on the health workers, I thought this quotation comes in quite handy. The simple truth is that there is no health without health workers. So if you're going to be talking about resilience, talking about response of health sector to shocks, we need to be talking about what happens to health workers. And I thought one immediately after that is to give you a sense of how important health workers are in systems. So here is the share of the health workforce's incomes, salaries, and so on, in total expenditures of on health. And what we can see, these numbers are large. In Malaysia, in at least in the public sector, the spending is around 60% of the government budget. In high income countries, and Malaysia is almost a high income country, the numbers range from 60% to 73%. The data is outdated because it's true. I mean, it's very hard to get good data on these sorts of things. But nonetheless, we're talking of a fairly large share of spending on health being allocated to human resources. And even in PNG, where the numbers appear to be smaller, there's also a data issue, but we can expect the number to be at least more than 40%. And in Africa, 50 to 55%. So roughly speaking, between 50 to 75% of all health spending goes to human resources. So if you're going to be thinking about resilience, if you're going to be thinking about all sorts of other health sector issues, human resources are at the center of it. Now, next part I want to introduce is the notion of the health market, health worker market. Now, I don't expect you all to be economists, but basically, but the language is pretty straightforward. That typically you would see more workers, health workers, in a sector if they were paid more. For example, of course, health workers certainly value other things, other attributes, job satisfaction, safety, access to schooling for children, and so on. So, availability of other complementary inputs. So let's park that to one side for the moment. And just for the moment, let's keep it simple. Higher salaries lead to a greater supply of health workers. That's whether in terms of time available or whether in terms of more workers available. And in generally, when on the other hand, if you look from the point of view of society and in the point of view of individuals, households, if the cost of a consultation is high, they probably want less services. And I can certainly give you my own example. The moment my copay went up, I stopped using less outpatient visits. So certainly, that's the way to think about this. So normally you would expect that as the earnings of health workers go up, they would tend to supply more of the services. As they go down, they would supply less, and less would join the workforce as well. So that's a simple story that I want you to work with as we think about some of the events that reflect the stresses I just spoke about. Okay, and so look at Malaysia now. Malaysia, I know they've been trying very hard to sort of stem this issue, but one big issue in Malaysia, at least in between 2010 and 2020, was the declining sort of numbers of high-end specialists in the Malaysian public sector, moving from the public to the private sector. And it's quite remarkable. If you look at this chart here, which we got from the Ministry of Health, is that the older the specialists get, that is, the more skilled and more knowledgeable they get, the less the likelihood of their staying in the public sector. And why would that be? You might argue, well, one good argument that's been raised is the salaries in the private sector, which has been growing very rapidly, by the way. The stress we spoke about is becoming very quite attractive. So when you're young, you get important experience, but once you become truly marketable and truly high earning, then of course the gains from working in the private sector go up very high. And so this is a sort of the hidden stress which arises from budget constraints, which is felt through the actions of participants in the labor market. This is a very simple example, but you could think of many others. It's the same sort of, what I haven't spoken about is another angle why people choose careers. For example, you might say, you know what, people choose the health work because there is of the prestige attached to it. So it's not just salaries, it's not just in cash, but also in kind valuation. Well, in that case, you might have a glut of certain types of workers. You might have a glut of doctors. Now, in Australia, for example, there is a glut of lawyers. They're doing all sorts of, because simply because it's considered prestigious. At some point, it won't be, but the market is basically giving you signals that this stuff is valuable, and whether it's in the marriage market or whether it's in the job market. And essentially what it is doing is creating a demand or for these sorts of workers, at least in their minds, and they're providing the services. Okay. Now, in PNG, where the funding is unreliable and low, it shows up differently. So there what we see is among the lowest doctor to population ratios in the world. I think it's 0.06 per thousand population. It's truly low. Um, and because funding is low, unreliable, complementary inputs are unavailable, and of course, schooling and other benefits are not there. Who the hell wants to stay in rural PNG, which is very, very sort of remote and lots of jungles and also. So most doctors are concentrated. I would say 80% or maybe even 90% are sitting in Port Moresby or similar provincial cities. High staff vacancy rates in rural areas. So you're not paid very well. Your salaries are, who knows when they arrive. Your interests are not to sit in a rural area. You don't, and this is not even attractive. So certainly, one thing that you see is the markets are playing out. And when I say the market, I'm using it very loosely. The notion of value, the salaries, I'm using it to capture literally everything that you value about a job. That essentially leads to this sort of behavior, which in turn leads to this sort of an outcome. And one element of that, for example, if you look at measles vaccine immunization rates in comparing China and Korea, of course, which are off the charts, but if you look at PNG, it's been low. I mean, in this day and age, if you have a vaccination rate of 35%, it's considered very, very low. And PNG certainly falls in that category. And yes, you can say part of the story is about money for vaccines. But another part of the story is simply unavailability of health workers to deliver these vaccines where they're needed. So that's something that's an issue. So again, the market is reflecting the stressors from outside. And then we have another emerging issue which people haven't looked at so carefully, and which is the whole issue of rehabilitation and social care. And the reason I'm not presenting the data for this is because this data is actually quite thin. In fact, data availability is a major issue. But what we do know is there is a massive shortage of qualified workers. I mean, forget about Malaysia and forget about PNG. There's a huge shortage in Australia. So, and then the question that arises is, even if you don't have the data, would you expect, and certainly the current conditions in the market are telling us that whatever the market predicted in the past was incorrect. Is the question, is the market correctly predicting what is needed? And my guess is not, because at best, it can rely on what people can afford to pay, because the government is not thinking about it. Or even if it is, it's not really investing heavy money in purchasing these services. So the issue then is relying on private affordability, which matches well with the availability of private money in the health sector and social care sector. But of course, this tends to be quite inequitable, because then you're neglecting population need and people who might actually need these things, even if they can't afford to pay. And of course, there's a long-term effects on resilience, because we're talking about, if you don't have access to social care, then people often stay in hospitals longer. In fact, one reason why I found that smaller Malaysian hospitals, public hospitals, tend to have very long lengths of stays, that people are basically substituting social care for longer hospital stays. And again, that's not unique to Malaysia. I've seen it in many other countries where people are simply substituting hospital care in place of social care. Okay. And then finally, the final set of thoughts on this, well, a couple of thoughts, that in fact, the production of human resources for health and social care is another major issue. So it's not simply that you wish the demand to go up today and these people will appear by magic. There are often quite significant lags in the production of human resources. You know that for yourself, from production of doctors, nurses takes very long periods of time. But even if it's social care workers, even that takes time, because ultimately you're talking about infrastructure, buildings, capital investments, teachers, all of them have to be obtained, a curriculum has to be developed. All of that is very, very time consuming, and especially when it's context dependent and so on. And then there are, of course, in a market where budgets are limited or things are uncertain, you tend to migrate. So migration risks are a big issue. And certainly that's true of the Pacific, with its already low level of health workers. And it's certainly true of, I've seen some data from Malaysia, that you probably have a glut of doctors, but probably issues around nurses. And so one way to handle it is by sort of offering higher salaries. And I understand in Malaysia, they've been trying to hold back on their qualified nurses by paying them more. But all of that affects, in turn, the system's capacity to deliver services in a way that is affordable, sustainable. And that makes it go back right to the resilience questions. So what I'm basically saying is an important mechanism through which these stressors take place, or they're felt in a system, and how the system can actually, well, show its resilience or not is through the health labor market. And I've not even introduced the idea of people's career choices, how they decide whether they go into the medical care sector or the social care sector and not into engineering or molecular biology or just plumbing. So all those factors are important, and when one thinks about, so one has to do very long-term planning, and so we shouldn't think about these issues around dealing with these risks as a short-term thing. These are, even if it might appear that NCD risks are very long-moving, so is the system's capacity to respond to the health labor market. Now, you might say, well, do I have any magic solutions? What can be done? So the best thing to do here is to stop and allow for some discussion so we can exchange ideas as to how one can think about addressing a challenge such as this in the context of ensuring resilience. Thank you very much.
Thank you, Prof. Ajay, for the very insightful lecture. Are there any questions from the floor?
I know it's not very clinical, so
No, we have a few experts in health economics.
Very good.
Maybe I can start with one question, Prof. Ajay. Wait, hang on. Yeah, let me just check again. Is there any? Okay, so there's one question from YK Chan. Prof. Ajay, if you could.
Sure. Let me see let me look at the question.
Yeah.
Yes. I don't see any question actually.
Okay, maybe I'll read it out to you.
Yeah, sure.
We used to enjoy a system that meets the needs of our patients and a system that once lauded as being cheap and good. Now, as the salary of other health systems have attracted our workers, we have seen a decline in the numbers of workers supporting the system. Does a lot of other health systems globally suffer from this problem?
All I can say is depends which health system. Australia has got no problem with doctors and nurses. It's basically is sweeping up, vacuuming workers from the region. And what is truly interesting to watch is how even some of the doctors who come from other countries, including from Malaysia, I've seen, who completely drop their medical career and move because it's kind of expensive to move. They often become public health specialists or simply choose academic careers. It's quite interesting to watch this. So yes, but I think in general, countries like India, a lot of countries in Africa which are already short of workforce, certainly PNG, same problem, perhaps even on an even bigger scale than Malaysia, because Malaysia, I think, actually has production capacity for health workers. Many of these countries can't even produce health workers. And when they do send a few of them to get trained, they never come back. So I think from that point of view, Malaysia's challenge certainly is there. I think, but your challenge might more be of an internal issue, internal migration from public to private. So this is a challenge for almost all systems that have a mix, sort of public-private mix, and there is no easy way out of it. And that's why it's important to think in terms of transformative strategies, because ultimately you will run into a problem of massive departures in the public sector. I have to tell you, it's an interesting statement which I heard from a very well-known economist in the context of India, because they said there's no point helping the public sector because it's a corpse, and you don't put band-aid on a corpse. Now that's not the sort of thing you want to hear in the Malaysian context. But then India abandoned its public sector almost 40 years ago, at least in terms of significant support. And so, yeah, there is a risk. Many countries face it. Some are at an early stage, and some are, of course, enjoying the benefits of all the health workers in their countries, and so on.
Thank you, Prof. Ajay. There's actually a follow-up question. How to get the health minister to listen to the issues properly?
I would say constant communication. And I think one thing that I do believe, and I've not been seeing recent research articles on Malaysia, I've not been tracking them, but I think what people neglect, the player that you need to pay attention to is not the health minister. The player that you need to pay attention to is the finance minister. And so my sort of suggestion would be that rather than just leaving it to the World Bank or the Asian Development Bank or similar entities who do a lot of good work, I have to admit, in thinking about broader challenges and how is actually to be to be right there, to write about it, and to actually strengthen your skill sets and even your students. You said there were health economists there. That's very good, you know. But again, remember, it's not simply a question of health. It's also a question of the education sector, the labor market, the Ministry of Labor, and so on. So ultimately, you have many, many other clients. So, and the best way to handle them or reach them is through the Ministry of Finance. So I would argue that that's a true client. The Minister of Health will be fine, but ultimately it's the Minister of unless the Minister of Health is some powerful cookie who I don't know who the current Minister of Health is in Malaysia, but if not, the Treasurer, the Ministry of Finance is the name of the game.
Right, Professor. There are two more questions.
Sure.
What do you think is the solution to the unbalanced intersection of quality of healthcare with the economics?
Can you elaborate a little bit? I want to understand the question a little bit better.
Basically, I guess the question is to identify what is the solution to the unbalanced intersection of quality of healthcare with economics. There's no elaboration here, but that's just the question asked.
I'm trying to think. Look, if the question is that economics often drives poor quality care, well, usually a case could be made that if you don't have good regulatory systems, then you will, of course, you could end up sacrificing quality for economics, purely money. But then, as I said, I do believe that when you think of economics, one shouldn't think totally in terms of salaries. It's about job satisfaction. It's about doing good. All of that stuff is also a return, even if it's not pecuniary. It's non-pecuniary benefit. So certainly that, coupled with good regulatory systems, are often key. Now, I don't think Malaysia has a big issue regarding. I mean, my sense is Malaysia is pretty good in terms of quality of care and so on. But I think this is a relevant question for many other countries that are short of people and where regulatory systems are weak. So I would argue PNG would certainly fall in the category.
Right. The last question, Prof. Ajay, from Prof. Tengkusara, I think. Amazing how you know the data from so many different countries, and the comparisons are very interesting. Many of our health workers are spouting doom and gloom, where the health system is going to break down anytime soon. Do you agree?
Nice rhyming.
She just wants to know, do you agree with this?
Look, I mean, I sort of think that any system, if you don't do anything to it, will ultimately collapse because the outside stressors, movements, things are always changing. So I in general, the ability to sort of dialogue, discuss challenges on an ongoing basis is key to ensuring that health systems don't run into this doom and gloom scenario. I think in the typical tendency of policymakers is not to rock the boat. And why should they? They have a 5-year appointment, and at the end of it, or 4 years, depending on which country you're in, and that's the end of it. So I think it's incumbent upon us, not just researchers, but also for researchers to get more engaged with policy and so forth. So we're constantly in the rear and constantly sort of, this is what we can do at least. So I sort of say that, you're living in a pretty wealthy country with a reasonably, my sense has been that the leadership even in the Ministry of Health is quite good actually compared to what I've seen elsewhere. And so all that being said, I think the idea of engagement is going to be key. That doesn't solve all your problems, but I think if you're engaged and so on, I mean, I like clinical research. I'm very fond of the silver bullets, but ultimately the big silver bullet, there's no silver bullet as such for the health system problems. So I would argue that rather than take a doom and gloom perspective, the perspective should be one where you sort of about constant engagement, constant renewal, constant change, and sort of recognizing that economics is an important element of whatever goes on, and incentives, motivations are going to matter. So I think that's. I mean, I don't know if I fully answered your question, but certainly so that's what I would say. I mean, everything can be recovered, but the more you wait, the bigger the political cost you have to pay to make change. Is how I see this. So I think that Malaysia, for example, the longer it waits for the private sector to keep growing, the harder it would find to ultimately, to sort of bring people under the same boat. For example, if you have universal insurance or some common payer or something. I mean, the classic example, I mean, just to give it how powerful doctors can be, I mean, and you know this, is that in Australia, when they tried to introduce a single payer system in the 1940s, or at least a significant, oh no, I take it back, a single payer for, for, I think, for procurement of medicines. The doctors said, I hope you're not going in the direction of socialized medicine, i.e., single payer. The government said, no, we have nothing to do with this. We are just doing pharmaceuticals. They said, we don't trust you. And they said, put it in the constitution, so you can't change the constitution, that you will never socialize private medicine. So, what I'm saying is the political costs of changes become much higher if you're not tinkering with the system more or less or discussing it on an ongoing basis.
Thank you so much, Prof. Ajay. I guess those are all the questions we have for you for today.
So another word for resilience is political cost. Okay. So or lack of resilience, I should say. Thank you very much.
Thank you, Prof. Ajay. And thank you very much, everyone, for a very fruitful discussion today. With that, we'd like to end this session. Thank you.